Good afternoon, everybody, and welcome to the Community Technical Assistance Center of New York. Our webinar today is called Learning to Love Data with Dr. Jeff Capobianco, and we will get started in just a second, but I just wanted to walk through a couple brief housekeeping things about the webinar, especially if it's your first time with us. Everybody is muted, so if you would like to talk with us, you'll have to use the chat box. If you hover on your screen, if you don't see your chat box on the right, if you hover on your screen towards the bottom, you'll see a series of circles. One circle has a bubble in it. When you click that, it opens the chat screen on your right. So you'll be able to communicate with us through there, send any questions, comments, feedback that you may have. The presenter today may be able to address some questions throughout the webinar, but if not, we will also have a Q&A period at the end. Today's presentation is being recorded, and the slides will be posted on our website at www.ctacny.org within the next 2 days. So make sure to check back on the website if you want the slides or the recording, or if you would like to share it with anybody. At the end of the webinar, we do have a feedback survey that pops up, so please, before you completely close out of the browser, please take just a couple seconds to let us know how you thought the webinar went, and if you have any additional feedback for future trainings or additional comments that you may have. Okay, without further ado, I would like to introduce Dr. Jeff Capobianco. Jeff, would you like to get started?
Yes. Thank you. Thank you. I appreciate that. Hi, my name is Jeff, and I'll just give you a little bit of background on me, and then I want to give a little background, too, on this title, Learning to Love Data, because I really like the title. It's very eye-catching, and the concepts we're going to be unpacking at the end of the webinar. I don't know if you're going to love data, but hopefully it will be in a place where we better understand really how to leverage it and use it to help our clients and help our organization. So I'm a psychologist by training. I hail from Michigan. I live in Ann Arbor, Michigan. I work with the National Council. I work with the University of Michigan. I do some private work also. And I'm very lucky that I get to travel around the country and do consulting with organizations and learn what smart people are doing in the field today to really respond to where the field is. And if you look at the learning objectives we have today, the field is very much focused on value, very much focused on using data to inform the value proposition from the standpoint of people getting better that you're seeing, but also that cost is being at least contained, if not better understood. So this idea of loving data is one where we are in bed with data. We have to get to know it better. Many of you already do this well. You're in the state of New York, which I would say, I'm working in about 12 states right now, New York is ahead of the field as far as looking into the value-based purchasing space with all the work that's been done with DISRIP and all the other work that's going on in New York. You probably are in a better place than most in the country to see how to leverage data and to see the demand in the field right now for its use. But that isn't to say that there isn't, more work that we can do together. So we'll get into that today, and there's a lot of places that this presentation can go as far as bringing up ideas. So I'd love to have discussion through the chat box with you as we're going through this and learn more about your perspective and what you're doing with these concepts that we'll be talking about with data. I am somebody, as I mentioned, trained as a clinical psychologist, spent about 15 years doing clinical work, and one of the things that frustrated me a lot about my clinical work was not really knowing in a really measurable way whether people were getting better. Now, again, I was working in the clinical space several years ago, and things have gotten better, but I think having data to point to say, yeah, someone's symptoms have improved, not only they're telling us they're getting better, but we actually have some validated instruments to help tell that story also. I think the other thing that we'll comment on here is this reframe around how we think about data. We have a long history in our field of beating up staff with data. productivity measures, billing, did you bill for that, face-to-face time, and it really has turned a lot of clinicians off, frankly, and that's completely understandable. We also have a field, if you've been around for a while, you remember the turn of this century, the push for evidence-based practice and the use of fidelity monitoring and really getting into measuring fidelity wasn't always well received by staff. They really thought it as, they saw it as, somebody else kind of coming in and telling them how to do their job. So data is not something that people typically love in our field, so we'll work on that today. We're going to make a link between quality outcomes and clinical decision-making and really education of your client using data in this presentation. This overlap between quality improvement, health literacy, and then actually working directly with your client or their parents if you're working with young children around how to use data to bring about health literacy, to really explain what you're doing with the client and their progress and how that all plays out with data. We'll be getting into that. So let's jump into it. I mean, if you're like me, data wasn't always something that, or measurement that you always got excited about. It's not why we got into the field. We're not engineers. We're not people who like to measure things and, use math a lot. Some of us, get confused quickly when you get a bunch of data in front of you. Some of us, it just puts us to sleep. Others just are stressing out and have a lot of work to do all day long, and the last thing they want to do is talk about how data is telling the story of the work they're doing. We have, if you look at the guy in the upper left-hand side of the screen, I think there is information overload in our society, not just our field, certainly today. So it makes, the digestion of all this information we're getting quite difficult. So we're going to talk a bit about, these distinctions between data and information, how to leverage it. These are some common responses I get from students, from clients I work with when I talk about loving data, when I actually show excitement around data and measurement. Sometimes people really look at me kind of out of the corner of their eye, and they don't know whether to feel sad for me or to run away or be afraid of me. And these are just some of the comments, that I typically receive. And it's in the general sense that, yeah, these data are just another thing we have to do. I don't really see it as something helping me in my day-to-day work to become more efficient or effective. I don't see it as being really helpful to my clients because, frankly, our EMRs aren't easy to use, and we report a lot of data to the state or whomever, and we never hear back about it. So this is the general, themes that I usually hear from people, and it is completely understandable that we hear these things. Value-based purchasing, value-based approaches, or value-based contracting, also known as alternative payment contracting. This is very much alive today. If you've been around for a while, you know that, in the 90s was the decade of the brain where we were getting into a lot of brain science and understanding how mental illness and substance use is really a brain disorder. And then at the turn of the century, we had a big push for evidence-based practices, integrated dual disorders treatment, family psychoeducation, the Texas medication algorithm. You remember the SAMHSA toolkits. And then we were hit hard about 2005 with integrated health. That was the thing. It still is the thing. And then the Affordable Care Act came along, and we hear value-based purchasing. If you look at the slide, this is not a new term. This is a late 90s definition that I like. Value-based purchasing was first talked about, in the 60s and 70s, actually. It's just really come home to roost with the Affordable Care Act, and it's really sticking around because of how it's playing out in Medicare. If you watch Medicare, everybody follows Medicare. So Medicaid, third-party insurance follows Medicare. And if you'll remember, when CHIP was reapproved, I think it was in the fall of 2015, there was a big push for value-based approaches to measuring how Medicare dollars are spent. And that was very bipartisan, and that has remained. Even with the Trump administration coming into place, A lot of things in the Affordable Care Act were challenged, but the Centers for Medicaid and Medicare Innovation, that is still in place. These value-based approaches are still in place and still encouraged. So this is not going away. And what that means to you as a clinician or you as an administrator is we're going to be hearing more and more about how to leverage data to tell the story of the value proposition for your clients to show that it's getting better, and for your funder stakeholders, for the people who are paying you, to say, here's the value proposition that we are bringing to the table. So again, you guys are in New York, so this isn't probably entirely new to you. I don't know if you guys were around or heard, a couple years ago, Elon Musk sent a car, one of his convertibles, into space with a mannequin and a spacesuit in it. And I guess it, kind of just left the Earth atmosphere and is floating off into space. And everybody was amazed by that, and as was I. I thought it was pretty cool that could be done. For me, and I'll borrow some terminology from Dr. Solanero, who works at NYU, to me that was complicated. It was hard, but if you throw enough money at that, you can do the math, get the engineers, and you can actually get that car in space. That's complicated. When you look at this slide, this is what you guys do every day, or you're in the direction of going to be doing in the future, and I'll talk about that. This is complex. These are things that it's very hard to do the math around. The reason why healthcare is so difficult is because if you throw money and engineers at it, or money and us at it, it's still very complex. It's not complicated. Complex things are not easily measured. Complex things are not easily costed out. And that's where we are in healthcare, and that's part of why we love the work we do, because it is very complex. It is not simple work. And part of what makes it complex is the fact that the people we serve are our products, meaning people come to us and they want to feel better. They are the customer, but they are also the product. They want to become a healthier, happier, less symptom-bothered person. And that's very unique to healthcare. It's also unique to education. Those are the two fields where your customer is your product, or your product is your customer. That's not true if you're selling a car or what have you. So that adds a level of complexity to it that makes it difficult to measure. And as you remember from a previous slide, one of the comments was, what we do is too complex to measure. You can't measure someone feeling fulfilled. You can't measure recovery from a mental illness. And while I agree that it's something that you can't easily capture in math or data or numbers, I do think you can measure it. Some of the measures are going to be proxy-based, but I do think that you can measure most, if not everything, that we do. So if you look at this slide, on the left-hand side, we have what we do. We do a biopsychosocial assessment on the people we serve, and we capture their physical health, their mental health, and their substance abuse. And just to keep things complex and not complicated, we also capture their social determinant needs, which is very unique in the safety net population that we serve, that we as safety net providers really have to spend the time doing that, and we do it well. We do it better than anybody in healthcare. Whereas primary care, third party, they're starting to come around to social determinants and having to really capture those data and measure them. If you look at the far right end of the slide, here are our target parameters. These are the things that we're shooting for, or the measures that we want to be able to hit based on our biopsychosocial assessment. So these, will be obvious to you all as process and outcome measures. Process measures being the things you measure along the way to an outcome being something like they no longer smoke in this example, or they no longer are self-harming. The work that's done in the middle, again, is a process measures that are all measurable. And we need to look at level of engagement. How well is this person understanding what we'd like to do with them? And measuring that using motivational interviewing rating tools, hopefully, where you have readiness tools that measure someone's level of confidence and being able to achieve a goal that they've set up with you. We can use the pre-contemplative all the way up to maintenance or relapse prevention as a way for us to develop a mental model around where the person is in their level of readiness. And then we typically slot them into a level of care or level of service criteria, whether we're using the locus or the Cal locus, or a lot are using the DLA 20 now, to find out where overall this person's going to live in our services. Are they going to be high intensity and go into assertive community treatment, or are they going to be lower intensity, kind of a meds only, although those are terms that usually aren't funded, but essentially receiving some outpatient support around their symptom management and medication. And then we develop a service bundle, a treatment plan, a person-centered plan that, again, is complex because our customers are our product. So we might design a treatment plan and they show up the next week or 2 weeks away and they say, I don't recognize that treatment plan. I like smoking. I didn't want to stop smoking. And then we have to pivot and go back to level of engagement, re-educate them on what our position is and where we're coming from, learn from them, be a student of them, learn what they want out of their life. And then this column here that says length of care, time to treat. This is a new column for us, and this is not yet fully here as it relates to value-based purchasing, but it's definitely in states like New York, it's being talked about. And this gets into how long is it going to take someone to get better, how much is it going to cost, what level of care do they need to be in, so stepping people up and down in care. And this is where we talk about things like episodes of care, where we have somebody who's coming in who's depressed, that starts the episode, they're no longer depressed, that ends the episode. How long did it take? What interventions did we use, and how much did it cost? Now, again, measuring depression is a lot less complex than measuring someone who has depression, diabetes, social determinant needs, and other health conditions. That makes depression not so easy to treat because it intermingles with all these other conditions, as you well know. So this is kind of where we are in the field, and to me it's an exciting place to be because it's helping us look at what we do differently and really helping us get credit for what we do, to be honest. So efficiency is a fee-for-service model where we just need to make sure we have our productivity numbers. We have enough face-to-face time. We've seen enough clients. We have not many no-shows. Things are good. Effectiveness is looking at people where we actually see that within 3 months the PHQ-9 scores have fallen below, a point where the person would be diagnosed as depressed, or symptoms have come down based on some symptom rating scale. Or if you're looking like the Scott Miller session rating scales, that people better understand what I'm trying to do as a clinician, and they're liking their sessions more. They're feeling like it's useful to them. It's effective for them. So these value-based models really push us in the direction of being not only efficient, billing, seeing people, reducing no-shows, but actually being effective. And for me, that's an exciting proposition because it allows us to be able to really get credit for the value we're providing the field, and then ultimately getting paid for it. Because if we're looking at our care pathways and we know how much they cost, and we know what it takes to hit those treat to targets, we can then advocate for ourselves as providers and advocate on behalf of our clients to say, we need to get this amount of payment to get these outcomes because we've measured it and we understand it. So why is data, let's take a minute and just talk about why it is that data is such a pain to actually use and leverage. And when we look at, in 2010 when the Affordable Care Act came into place in March, there were a lot of discussion about electronic medical records. About $19 billion went into the EMR space to get electronic medical record companies to get them up and running. And if you're like me, still don't love the EMR I use, but it's better than it was. So the main reason, when we look at data being tough, early on it really was aligned with this IT trouble we have with our EMR and aligning it with decision support in the clinical workflow. And I think we're still at that point today. I think you would all agree that your EMR could better support you in providing clinical care. Fewer clicks, better, decision support and recommendations around treatment planning. There's a lot of things that could be done. But if you've been around for a while, just think back 10 years ago when you first got your EMRs, they're probably better. When we look in the field of management information systems and we talk about what is really effective in helping the data be more helpful to clinicians, one of the things that really jumps up is that the organization take a really hard look at how they as an organization use data at the senior executive level and really having a leadership plan for how data are going to be leveraged to tell the value proposition to funders, to tell the value proposition to the board, to tell the value proposition to the staff so their experience of care provision can be better, and then ultimately to tell the story of how people are getting better and telling the clients how they're getting better using these data points. And when you look at some of the areas in the business world where they've looked at how do we get organizations to better use data, there's a nice little acronym in Davenport's book, which is a great book if you ever want to really get into the weeds around data and analytics. But they found that you really need accessible, high-quality data, which I think most of us have today. We might say, we don't have enough of it, or some of the data isn't as clean as we'd like, but there are data points you can access today, most I would assume, in your EMR, and you could say, yeah, those data are reliable, meaning they are consistently being captured in the right way, and that they're valid, meaning they're telling the story, the correct story about whatever we're looking at. So our PHQ-9 is a reliable instrument. It has valid data, meaning it actually reflects the depression symptoms of the client. So I think most of us could say we at least have some data to work with now in our EMRs. They suggest that you have a real enterprise orientation and analytical leadership. This means that your leadership are using data to tell the story about the strategic approach the organization is taking in the marketplace to either expand services, make services better, whatever it is in your organization's strategic plan to better execute on helping people. Leadership has to have data at the ready and know how to actually use the data to tell the story about what's going on in their organization and use the data to get kudos around the value proposition when things are going well and to market it to staff, clients, funders, but also use it to recognize when there are breakdowns or things aren't going well and really design quality improvement activities around that. Strategic targets and then analytical talent. So the targets are what we've talked about. Clinically, we need a measurable target for all the aspects of care we're providing for clients. So if they're not housed, we need a measure around housing, obviously, and that would be that they get housed. At the strategic level, though, at the organization level, whether you're a middle manager or a senior manager, you also need targets, annual targets for where do we want to be in a year. What is our organization going to look like in a year that's different from how it looks today? And how do we measure that? What does it actually look like? Are we going to have this many fewer no-shows? Are we going to have this many more value-based contracts that we really feel we can execute on and at least break even around? Are we going to have this, many fewer staff turning over? Really using those measures as our way of knowing if we've achieved what we've wanted to do. And the analytical talent piece is an important one from the standpoint of once organizations really start using data on a regular basis, you get staff and you get leaders who start to hear the story that the data are telling them, and they get confused about the story, and they'll start making pronouncements around, we have a 60% reduction in our smoking rates with the clients we serve. And well, that might be true. You really need a data analyst, somebody who has expertise in data to start interpreting what the data are telling you when you get to that point. And many organizations have actually hired or use university staff or hired data analysts to help them with their data aggregation to tell that story so that they're not making wrong claims about what they're able to do with their services. Ultimately, we want to get to the point where our staff understand the critical numbers that they're working with, and they know where the numbers come from and they know what the numbers mean. And this really comes out of the business world in this approach called open book management. I don't know if anybody's heard of this. It's typically used in small to mid-sized companies. And I'll give an example of a restaurant I visited where they used this way of leveraging data, explaining the story of data to their staff to really make their restaurant very, very efficient and effective as a restaurant. What they would do on a regular basis is, weekly they would have the shifts come in and they had a big whiteboard, and the hosts, the hosts and hostesses, the wait staff, the kitchen staff, everybody would put their numbers up on that board with magic marker. And these were numbers like how many plates were returned, how quickly tables turned over, any complaints they had from staff, the cost of the food they purchased and what food spoiled and they can't use it anymore, so they lost that money. And the whole approach was to have targets for service provision linked to cost. And the idea with open book management is really to have every staff be able to know what the data means, where it came from, and be able to teach and know these rules to new staff that are coming on board, to really understand the data and keep score on how well they're providing services, and know how to respond to the data when the data don't look good, to know whether the data don't look good because the data are wrong, maybe we're capturing the data wrong, we're not using the protocol correctly, or to know the data are right and we have something we need to fix with a quality improvement process. And then finally there on the bottom, provide a stake in that outcome, to be able to really engage each other but also the customer around what these metrics mean and to be able to have that conversation with them. So that's really what we're shooting for in healthcare also. So if you think about what is the difference between data, what's the difference between information, knowledge, and I'll kind of play this out here. Data is just the starting point when we want to be able, as a clinician or an administrator, do something useful with data that's showing up either in a spreadsheet or in a dashboard or a registry report. Data is just a granular or one point of information. It's something that's unprocessed. If you think about a blood pressure, it's got two numbers on it. It's got a systolic and a diastolic. The top number, 120. Bottom number, 80. So 120 over 80. Systolic is just one data point. Diastolic, just one data point. And it tells you the pressure in a patient's arteries at one point in time when that blood pressure was taken. So it's actually two data points, and it's useful because it gives you information around where that person's blood pressure is. So it moves from being just a couple of data points into information because it tells you a story about something. It says to you, hey, person who just took this blood pressure, their blood pressure is normal or it's not normal. So you know that because you have expertise as a healthcare provider. Same thing with the PHQ-9 or the CRAFT. You get a number, and it tells you where the person is at based on this tool. Now, it's got to be incorporated with other information. So when you got something like a score on a depression screening tool, you incorporate that with the whole biopsychosocial screening, so the clinical interview, all these things, and it moves from being just a point of data to actually being information that can tell you a story. It's telling you a story about this person. And then once you hear the story, you've got enough information to start making decisions. It actually goes from being a data point to a group of information that's telling you a story to knowledge, which means it is something that you can actually use as a tool at that point. It goes from just being information to being a tool that you can actually manipulate. You can actually take it and use it to impact service provision, impact someone's care provision, impact someone's view of their health by explaining to them, hey, you know what this PHQ-9 score means? It means that you've got this thing called depression. Based on this score and our clinical interview, I think you're somebody who has depression. So let's go through this PHQ-9 and look at these questions. It talks about your sleep. It talks about these things. These are all symptoms of depression. And then you go ahead and explain the difference between a sign and a symptom. So it allows you, when it becomes aggregated together, data allows you to then actually utilize it as knowledge that can be imparted, and ultimately it's put into action to help your clients. Now, this isn't shocking. I think you guys know these things. But what's useful from the standpoint of where we are in the field today is the fact that we need to do a better job of mobilizing this way of thinking in our clinical sessions, in our team meetings, and at our leadership levels if we're going to be able to survive in what is becoming a pretty aggressive value-based marketplace where we have to be able to show the information, our aggregate data that tells our value proposition. So any questions at this point? I see a couple over here. I can look. What does he find? What's further? There is no proper use of information. I think we all gather enough data. It is how we use these data appropriately. Yeah, really well said. Someone made the comment that we're data rich. We can get our hands on lots of data. We can even get information. We can get dashboards or we can get registry reports that convey how we're doing. The knowledge piece, how to take the information and actually turn it into tools that we can bring to the client or bring to the clinic, that is where we get into team-based care. That's where we get into the development of measurement-based care pathways. That's where we get into standard operating protocols so that we know if data are telling us a story that someone has improved, that they've crossed a threshold now where we can step them down in care. And we have a protocol that explains what to do with that information. That information becomes something that we can actually mobilize. And we will step that person down in care, and they will already know we're going to do that because we had already explained to them how we use these data points to provide care within our care pathways. So it's this intersection of doing clinical work with somebody and using data to tell the story about how well they're doing and how their treatment plan that they helped design with us is really working and giving them that knowledge about their health. This is where it intersects with continuous quality improvement. This is the same exact thing as Plan, Do, Study, Check, Act. And a lot of times, especially frontline staff that want nothing to do with quality improvement, they kind of miss this point. And I blame our quality improvement staff like me for this because what we've done is make quality improvement or continuous quality improvement this, CAR for accreditation thing with a quality improvement committee, and staff just, they either get excited about it or they want nothing to do with it. They see no connection with their day-to-day clinical work, and that's a real problem. So one of the ways that we've seen organizations be able to begin to leverage some new thinking around this is to take continuous quality improvement and really bring it into the clinical session, right to the client, so that your outpatient clinicians, your peers, your people out there in the community understand that they're already doing this. By providing good clinical care, you are doing quality improvement. It's the same thing. So if we're able to do that, to really start to move away from using data as a way to just talk about productivity and outcomes, no-shows, and move into talking about it as, hey, this is really a way to tell the story about the great job you're doing and how well our organization does execute on our mission and vision. If we can use it as an objective way to work with our clients and tell them, hey, look, you know what this score means? It means you did a great job because your symptoms are getting better, and we should celebrate this. Or you know what this score means? It means you're not getting better, or you're feeling worse, and we should celebrate that we've recognized that, and we can do something about that. So it really provides that level of health literacy. And I see a bunch of comments popping up. Yes, we will be sending slides out. What else do we have? I'll let you guys pull out some of the comments so I don't have to turn my head and read every one of them.
Sure.
But I'm interested in what you guys think of what I'm riffing on so far.
So there's one that says there are frontline staff who are not particularly trained to focus on larger picture concerns such as operational issues and quality improvement. What is the best way to engage with them?
Yeah, so it's always intriguing to me when I go into organizations and the frontline staff are not engaged in the development of protocols or the engagement, and they're really not engaged in the development of the strategic objectives of the organization, because the frontline staff are the ones that make the money for the organization. They're the ones that know what works and doesn't work with the clients to produce the outcomes that are needed, which is the value proposition that the whole organization is executing on. They are the ones that know if the vision and the mission of the organization are being delivered on. So they have to be included in that discussion. Now, does it mean the frontline staff develop a strategic plan? And no. I mean, that's why the executive team and the middle managers are there to prioritize the objectives and keep them very sharpened, meaning you don't have 10 priorities for an organization in a year. You have 3 or 4 until the organization is able to really execute efficiently and effectively on a couple metrics. You have 3 metrics to start with. But the frontline staff are the ones that know if those metrics are the right metrics, and they know how to actually achieve them. So as an executive, if I put a stake in the ground that in a year we're going to arrive at that stake, and that stake is going to have written on it 10% no-shows, and we're currently at 35%, me as an executive or a middle manager, I don't know the how. I know why we need to get there. I know what we need to do. I put the stake in the ground, the what is the 10%. How you get there, the frontline staff are the ones that have that expertise. So they have to be brought into the process of unpacking how are we going to actually get to 10% no-shows in a year, or even if 10% is realistic, and have that discussion with them, which is a quality improvement exercise. On the clinical side, if we have a bunch of people with diabetes that aren't doing well, it is the team and using team-based care that has to come together, review the care pathway, and find out how to change that number, how to get fewer people being obese, fewer people having really bad anxiety scores on their general anxiety disorder 7. They're the ones that know how to do that, and team-based care is the way to get there, which is outside of this conversation, but we can certainly have it, and I'll talk about dashboards in a minute, that are very useful for teams to be able to use as their touch point for, hey, are we doing well or not? The information they need to know how to act, how to actually leverage the troops or leverage the team to do things differently. Does that make sense? Or other comments?
Yeah, no, I think it makes a lot of sense. Thank you. I think we have a few questions coming in. I'm wondering if we hold those towards the end.
Okay.
Yeah.
Okay, so I don't think anybody would disagree with what I've said so far, but how do you actually pull this off? No right way to do it, but given the organizations that I've worked with, the ones that have been able to really do this well have really spent a lot of time looking at what is continuous quality improvement for the organization and what is continuous quality improvement help, if you want to call it that way, for in the clinical realm, the one-on-one clinician to client. How can we merge those together? Because that's what value-based approaches are really requiring us to do. And it's a little easier than I think most would think if they don't overthink it or try to do too much. we've got the time in the field before, we really see these at-risk value contracts really coming online, particularly in the Medicaid space. Right now we're about 15% of Medicaid contracts are value-based, and most of those have upside risk associated with them, not a lot of downside risk. But with Medicare, again, as I said, where Medicare goes, Medicaid goes, they're looking at 100% by 2025. I don't know if that's going to be the case even for Medicare, but this isn't going away. So it really behooves us as providers and leaders to leverage this. So if we look at just continuous quality improvement, I think you guys have seen this before. The Plan, Do, Study, Check Act. If you're a clinician, you typically don't think Plan, Do, Study, Check Act as you're sitting with a client, right? But you're doing the same thing. If you're an outreach worker, you're going to do a med drop, and the person isn't there when you go to do the med drop, but their buddy is. What do? You say to them, hey, where's Joe? Oh, I think he just walked up the street to get a Coke. You might be able to catch him. That was a Plan, Do, Study, Check Act. The plan was to go drop off meds. You did it. You showed up. You study. Oh, he's not there. You plan again. Hey, where's Joe? You do that. You just did that cycle, and you keep doing that. It's just basic human problem solving. You keep doing that till you get the result you want, until you get the meds to the client, or if you can't find them, you get back to the office, you write the note, you make the call, you go back out and see them again. So PDSA isn't something that's fancy or quality improvement based. This is just living. This is called day-to-day living. And clinicians don't give themselves the quality improvement credit they need to be able to pull that off. And if you look, this is a complicated slide, but I'll work through it with you pretty quickly. If you look at organizations, they make things complicated like this slide when it comes to quality improvement when it really doesn't need to be. So in the upper left-hand side, you have the strategic plan initiative. We're going to provide better smoking cessation services, everybody. Nobody disagrees with that in the organization. The executive director and the quality improvement team say we have a 100% performance target we're going to be shooting at. In 8 months, we want 100% of people to be screened for smoking. So nobody's not going to be screened for smoking that comes through our doors. Right now, we're at 60%, or we're at 50%. So what do? On the bottom here in your care pathway, you educate your staff about how to screen for smoking, the importance of smoking cessation, all these things. You educate your clients. They go to work. And they enter into their electronic medical record these individual data points. And they enter it in this blue box here as individual data points. They then become aggregated into information in the form of a dashboard that tells the actual performance of the organization. So in 3 months, we check back and we compare results, and the target was 100%, and the actual is only 60%. That gives us information that we can act on. So what action do we take? Maybe we adjust our objectives and say, hey, 100% was too much. Let's shoot for 75 in the next 6 months or something. Or maybe we keep it at 100% and we educate our staff more. Maybe people were confused. Or maybe the EMR module didn't have it really clear, like how do you type in the smoking cessation screening data. So essentially, it's a plan, do, study, check, act cycle, right? We planned it out as a strategic initiative. We did it in our care pathways. We used the data in the form of information to study what to do next, and then we acted on those data. When it comes to doing this in the clinical realm, we're doing the same exact thing. We're developing a person-centered plan with someone. We're supporting the client in executing the plan. We're studying whether it worked or not. Now, this is really critical from a data standpoint. Someone's self-report that they're doing better is great, and we want to include that, but we need to also include measurement-based tools in this assessment process. It is very common in our field for people to do a great job of capturing depression, anxiety, CAPA scores, whatever it might be at the biopsychosocial intake point. We collect these data, and then we don't return to them and look at them again and do really good population health management and risk stratification with the tools. So engaging and studying with the data with the client and having the client understand what these data mean and own the data and talk data to us like how's my PHQ-9 score looking? Or doing PHQ-9 scores at home on their own. That's the real key here, because then when we get up to the ACT point, we can celebrate, them getting better and then keep stepping them down in care because they're getting better and better. Or if it didn't work, then we have an objective point to start from to develop a better plan. So if you look at, again, if we applied this to our clinical experience, we've got a person-centered plan. We have a 30-day action plan, so that clinical plan can't be 1-year plan because that's too far out. Even 6 months is not great. Really shooting for 30-day action plans that say, within 30 days, how many cigarettes are we going to reduce in our smoking together, Joe Smoker? And then we enter those data, ideally using something like a diary card if you can. Not all clients will actually pull off doing a smoking diary card or even an emotion regulation diary card, but that isn't to say you can't do it with them in session and fill that card out with them when they come in, and then using that data, aggregating it to make decisions around whether their level of readiness was correct. Maybe you overshot. Maybe 3 cigarettes a day reduction over the next 30 days is way too much. Maybe 1 cigarette reduction, and that's where you get into using tools like your confidence trackers to be able to say, what's your confidence around being able to stop using 3 cigarettes a day? You currently smoke 20. They might say, I got, 50%. I think I could do it. I don't know. You really want to make sure that people are at least 80%, right, when you're doing motivational interviewing with them, that they have 80% confidence that they can execute on that goal. So you use numbers like this to really tell the story, have the conversation with clients. So I don't think anybody would disagree about that. Many of you already do what I just talked about. But how, if you are a clinician or you're a team lead, do you take this apart and really put it into action? This is what we've seen really work well for organizations and for either an individual clinician or a team. Pick a point in your practice or a concern your team has, if you want to do it at the team level, where you're doing a great job and you don't think you're getting the value proposition out of it. You really can't tell that story. Or something that's of real concern, where you think something isn't working well, people aren't getting better, and you want to look at those numbers. Find that data point. And I'll talk in just a second about what a good data point looks like. Pull that data and see where it currently stands and incorporate that into your discussions with your client or at the team level using a data tracer checklist. And I'm going to show you a data tracer checklist in just a second. And use that data to just do this continuous quality improvement exercise. Keep coming back to it. Are we at a point where our plan worked? If it didn't, new plan. So when we look at what's a good metric to choose, I really like this slide. It comes from a book called Data Fluency that talks about really how to put data into action. And a good metric looks like this. In the upper right-hand corner, it's accessible and credible data. They're easy to collect. It's data you're already collecting. Start with data you already collect anyway. Don't get super fancy and try to create data points. You're probably already collecting data that's useful to you that you don't fully understand, that you haven't leveraged out of the information realm into the action realm to do something with it. The lower right-hand corner, it's transparent and easy to calculate. This is really important for clients. You don't want to create really complex data points. You want to make sure that they understand what the data means. A bigger number means worse, a lower number means better, or vice versa. Something that, it's easy to calculate and there's a common understanding. The client is able to interpret it and have the data tell the story about whether they're doing better or not. The whole team is able to interpret the data correctly and know if they're doing well or not as a team. And then finally, that the metric can be impacted by the client. Really important that you don't measure things that nobody can do anything about, or that you're not focusing on measuring things that are going to take 5 years to see the number get better. Focus on things that you're going to see a number change at least in the next 3 months. So BMI, very important, but as a clinician, I wouldn't be stressing BMI too much. I'd be looking at what your daily activity look like. We talked about when you're watching TV that at every commercial you're going to stand up and sit down 3 times, and we were going to track your activity. Whatever it is, in a 30-day period, you want to really capture those data there. So dashboards are really, really critical. And I'm aware of the time, so I'll move a little quickly through these. I think you guys get it. Dashboards tell the story in pictures of what the data are, and they give you the information in such a way that the story is clear and that you can act on them quickly, realistically. When you think of dashboards, think of your Facebook web page. Think of your email. That is a dashboard. And there's all sorts of data you can put on your dashboards. And we can get you examples of dashboards. One of the really cool things about dashboards that we see in high-performing organizations are these risk cutoff scores, and then also looking at risk stratification, and that's a question that came up in the comments. We do have instruments that can give you a risk score that tells you if the person's at risk for getting better or getting well, frankly. Those are useful, but I only recommend you start using those once you get beyond, the point of just understanding how to use a couple data points and starting to understand how to use a dashboard. That's kind of an advanced level of data use, and many of you are probably there. It might be another area where we can go in moving forward. Benchmark comparisons are really important. So, am I as a team, are we as a team doing as well as the other teams, but also are we doing as well as national comparisons, groups? Really comparing your organization to other organizations and your teams to other teams. Cost really has to be built into your dashboards. What is the money burn on the clients you've served? And it's not to restrict services and tell people they used up all their money. It's to do this open book management stuff we talked about so staff understand as we move to a value-based environment, it's not about just billing and providing as many services as possible. It's about billing the right services at the right time for the right client at their right level of need. So you're stepping them into the right level of need and not over or under providing services. The dashboard piece also is really critical as it relates to understanding how the data are linked in your organization. If you look at the top of this pyramid, it's the client's treatment plan that is the most important data point in your organization. It's because that is where the rubber meets the road around your mission and your vision. If your vision and mission are being executed, people's treatment plan numbers are moving in the direction of wellness. Then you've got your staff caseload level data, which tells the story of every client they're working with, or your team, if you've got team level. And then you've got division level, and ultimately at the leadership level, the reason why that bar is so big, they're looking at all the data. So at the client level, we're looking at the client's cost data and their clinical data. At the leadership level, we're looking at everything, all the finances related to keeping the lights on, but all the team level data, all the client level data. And then something that's often missed as a dashboard data element is your supervisors, and that's on the left-hand side of this slide, supervisors' access to staff work plan data. So am I, as a staff, I need my own dashboard around whether I'm doing my job well as a clinician. And I, as a clinician or as an administrator, should be owning those data and working with my supervisor to improve those data. So this is another area where it gets really muddy, I think, sometimes, where you do your annual assessment with the organization and you never look at your work plan as a staff. That, is not a good way to run a business, and it's not going to work in a value-based environment because staff really have to be executing on their work plans and hitting their numbers. So wrapping up, the data tracer piece is a really good way to ask the questions related to a data point. So if you're providing clinical care to somebody and you're providing, the craft and the GAD-7, or you're a team and you've got some finance data that you have to monitor, go through these questions. What question do you want to answer about your clinical practice or your team's work? What data you have that could tell you that story? I don't think I do a great job of, keeping people on my caseload. They seem to just show up a couple times and go away. Well, second, third appointment no-show data will tell you that story. I don't think we do a great job of, treating depression. Well, your depression data at the team level is going to tell you that story. Then look at what tools do we use to capture those data And if you don't use a tool to capture the data, then you're going to have to get one that's reliable, ideally reliable and free, but reliable, valid, free, and that you can get into your electronic health record. If you can't get into your electronic health record, then you have to do the cost offset decision of whether you're going to run a separate Excel spreadsheet to capture those data, either as a clinician in your practice or as a team. And then developing a protocol around how the data are captured and used, so that if your whole team wins the lottery and doesn't show up to work next week, the new staff that are hired are going to be able to use those data because there's a protocol that explains how the data is collected and how it's used. And go through the questions around how am I using these data with my clients, with each other. What data is reviewed? How is it reviewed? When? How often? How is it used with my clients and funders? How do the accrediting bodies use it? There's a lot of data we capture, and we as clinicians or administrators really aren't clear on why did we capture that? Oh, it's some report we send to the state. These questions really help you unpack that and have a discussion about the utility of the data. So with time being what it is, I will stop there and just say that the takeaways today were really just to bring you guys to a place you already know, which is value-based approaches are in play. Data is critical to that. And to make this whole process easier, we need to be thinking about data from the standpoint of whether our clients are getting better or not as part of our value proposition, but also if our organizations are strategically positioned to really leverage those data to get the job done well so we can stay in business. So let's take some questions.
Yeah, so thank you so much, Jeff. I think that was a great overview. And we do have a few questions coming in. We'll see how many we can get to. The other option is maybe we try to answer these offline and post it with the blog.
I can reply with email.
That's great. So we have a theme in a couple questions, which is basically how to get buy-in from staff and clients, especially when there's things like assessment or screening fatigue happening, both on the provider side and the client side. So what suggestions do you have there?
Yeah, so it's really important that the felt need be honored. So whether you're a client or you're a clinician or you're an administrator, and if you've got information overload, you need to spend the time to really pick a metric that people care about and that is meaningful to them and that is either really frustrating them, making them angry, or even if they're really excited about it, like, I think we do this well, but nobody knows. Pick something that is going to be meaningful to folks. Let the staff decide. Let them choose. They are the how people. The executive folks are the why we're doing this and what we need to do. The how thing is really important. Like, how can we make your lives easier, staff? How can I better explain to you, client, whether you're doing a good job or not? Whether you're getting better or not. So start with one data point. The beauty of human beings is once you get a couple data points on a dashboard, you can scale up the dashboard really quickly and add more data points to this. And you see this, online, if you're building a car or whatever, they always start with like 1 or 2 data points that they have you work with, and then by the end of building the car, you're making 30 choices. That's just the way human beings work. So if they're not used to data, you start with 1 data point, and then by 3 months, you've got 3 data points you're working with and you're tracking and you're focusing on and developing protocol around. And then before you know it, the staff just kind of off to the races with it. That's been my experience.
Great. Thank you so much. And then I think we just have time for one more. We are getting a lot of great feedback saying that this was very helpful and a great way to frame the approach of using data that folks can communicate with their staff. So I think that's really great feedback to share. I think one bigger question that we received earlier on was that behavioral health doesn't operate along a straight line continuum. How do we use data to show value proposition over the long term?
Well, so 2 parts to that. I think they do operate on a straight line continuum. There's just circles in it, right? There's these cycles within it. So we can do a better job, I think, pretty easily by getting credit for what we do and having, treat to targets or whatever you want to call them. So there is work to be done, I think, with the care pathway process. And the second part of that was getting credit for it. Remind me of the second part of that question.
I think it was, it's just how do we use data to show a value proposition over the long term? So being
over the long term, yeah. Well, I think, that's, again, on the executives. So the value proposition piece is simply stating that we as an organization have defined our mission and vision as such. We provide the best mental health care possible. We define best mental health care as this, and having a measurable outcome to that. Satisfied customers, we can measure that. We treat depression in this way. On average, people who come to us who are diagnosed with depression get better in this period of time, on average. There's always going to be people that, are outside of those averages. That you really put a stake in the ground around the care you provide. That's what managed care wants. They want to know how much does it cost to provide this care, and what are you going to give us in return for data? And we can do that. We do that all day long. We just haven't been able to put it into this value proposition language that includes some data. And oh, by the way, managed care doesn't know how to measure it, and the rest of the field outside of safety net doesn't know how to measure it. We've been doing this work for a long time. We're in a place now where we can actually bring to the table some different ways of measuring it, and nobody's going to say it's wrong because nobody's doing it, clearly as it is. So we're in a really good position, but in the next 5 years or so, that's going to go away, and we don't want the managed care companies of the world defining how to measure stuff when we can do it better. So with that, I guess we're probably at the top of the hour.
Yeah, I think
that's a good thing to end on.
That's a great point. So thank you so much, Jeff. This was a wonderful presentation. We're getting a lot of great feedback. And for our audience, if there's any question you didn't really get to, we'll kind of walk through those and see if we can post them with the slides, if we really didn't address it. Just as a reminder, you can go to our CTAC website, ctacny.org, to access the slides and the recording. We also have here a couple upcoming trainings. So the evidence-based practitioner with our Dr. Tony Salerno as the presenter is coming up. Applications of play therapy. That's a follow-up to a previous very popular play therapy webinar, so we highly recommend those. And we're kicking off a kinship care series also by the end of January, so we have quite a few trainings for you this month and next. As you close off, there will be a feedback survey that pops up. Please complete that feedback survey. Let us know what other information you'd like or what other trainings or support you like around data, as well as any additional topics. So thank you again, Jeff, for today's webinar. I think this was a wonderful presentation. Thank you, everybody, for joining us, and we wish you a great rest of the day. Take care, all.